This case was interesting from both a diagnostic and a treatment point of view. The patient had a bisagittal split osteotomy with mandibular advancement about 3 months prior to visiting me. She was suffering a significant paraesthesia in the right mandibular nerve after that operation, and what she was complaining of was a toothache, in that she had a dull pain in the mandibular molar area. She couldn't localise the pain, and her dentist felt that it was the lower right second molar responsible and had referred to an oral surgeon for extraction of that tooth. The oral surgeon felt that given the tooth was in function that it might be better to retain it, and so the patient was referred to me. Examination was complicated by the altered sensation in the mandible. All the teeth were testing negatively to electric and thermal pulp testing, and there were no teeth that were tended to percussion. In fact, the only positive test I could find was tenderness to palpation when I palpated lingually over the apex of the second molar. We took a couple of periapical radiographs. Obviously, it was going to be difficult with this plate here, and these are what we came up with. A few things to take away from here. Perhaps we've got some lucency in this area around the second molar. First molar, we can't really see the periapical areas. Obviously, we're a bit concerned about the position of the screw and whether it's interfering with the root of this tooth. We wanted to make sure that we weren't dealing with some problem with the 6 instead of the 7, even though the 7 is the obvious culprit. We can see that there's some sort of material in the pulp chamber, and the access has probably been over prepared a little bit here. Another thing that we see when we look at the second molar, we've got two different angles here. In this view, we can see that the distal canal is not particularly well defined, and then we have what appears to be one mesial canal. If we have a look at this view, which was from a slightly different angle, distal canal is a bit more well defined here, but we still only have the appearance of one mesial canal. And we also have this slightly lucent line through the middle here, which is obviously not a complete separation of the root. When you see something like that, you're immediately suspicious that we might be dealing with a C-shaped canal. We took a cone beam CT scan, and we can have a look here first. We'll look up here at this view, and we're going to move from top to bottom through the tooth, and you'll see that we'll view the pulp chamber, and then it will split into a mesiolingual canal and then a distal C-shaped canal, so quite a broad canal. Then down it reforms a single canal and then curves distally. So coming back up through it here, we can see that one canal splits into the two with a C shape on that distal canal, and then back into the pulp chamber. We'll just go back through that and have a look at the periapical area. What we're seeing is we've got a lucency around the root apex and some resorption of the cortical plate here. Remembering we had paraesthesia of the mandibular nerve, the lingual nerve was intact, and when we palpated down here we were getting some sensation. So either there was still some sensation occurring with this acute inflammatory reaction down here, or it was simply that the osteitis that went with that was also causing a little bit of inflammation in the mucosa. We'll have a look in the coronal view, and we're now moving from front to back. We can see that one canal reforming, moving distally, a little bit buccally as well. This is the inferior alveolar nerve canal here, moving up, splitting that distal C-shaped, and then the mesiolingual canal, and that's showing that bone loss or that lucency around the root. We'll go up to the sagittal view as well. What we can see here is the position of the screw that we were talking about, and it's either in or very close to the distal root of the lower 6. Now that lucency doesn't necessarily indicate loss of tooth structure or hard tissue around the screw. We often see artifact around metal in a cone beam CT, and I don't see any reason that we should be doing anything with this tooth now when we've got an obvious cause for the pain in the inflammatory lesion associated with the second molar. So let's just go on and look through a sagittal view of the tooth. We're going buccally now. We can see clearly that distal curve and the bone loss. So that's a pretty good indication of the anatomy that we're dealing with. We certainly have a better idea of what we're dealing with now than we did through examination and through periapical radiographs. Once we got into the tooth, this is after a little bit of coronal flaring. We've just taken away the restorative material. We found our canals and flared a little bit. This is the distal canal, and you can see the fin that runs from that, and there's a little groove through here, and this is the mesiolingual canal. I've drawn an outline of where those canals run. So your mesiolingual canal in this case was running down and curving a lot, but relatively gently through to the apical part of the canal. The distal canal came down and merged into that main canal, I guess. So most of the preparation of this apical part of the canal had to happen through the mesiolingual canal. If we put files down into this distal canal, it would need to make quite a sharp curve into that apical area. The apical part of the canal was gauged and prepared to a size 5502 using M2 and then FlexMaster files. After that, lots of passive ultrasonic irrigation was used, so placing sodium hypochlorite into the canal and using an ultrasonic file to activate it and allow the sodium hypochlorite to move into all those areas that are inaccessible to our files. I think that's quite important in regular shaped teeth like these, that we can get that irrigant into the area so it can do its job of dissolving pulp tissue, dissolving necrotic tissue, and killing bacteria. And you can see the anatomy in this video. We've got a GP point in the mesiobuccal canal. Preparation isn't quite complete, but you can see as we move that GP point that it's passing underneath the distal canal. So those two canals are merging at that point. The tooth was dressed with calcium hydroxide for 2 weeks. Symptoms were relieved fairly quickly after the preparation appointment. I obturated using the continuous wave technique, and that's a thermoplastic technique, so heated GP technique, and it's for sure the most appropriate manner with which to obturate these teeth. Here's a photo of the pulp chamber after obturation, and you can see that using that softened GP we can fill all the way through this fin, the distal canal. The periapical radiograph shows a pretty typical presentation after you fill these teeth. And what we can see, there's the mesial canal, the distal canal with the fin coming off it, and that's filled with sealer and hopefully some GP as well. And we can see this area where we've got the C-shaped distal part where the two canals merge as well. Appears to be reasonably well filled, and down through to the apical portion. We're planning to review this tooth in 12 months' time, and at that point I'll take a cone beam CT and we can see whether we've got any healing in the apical area.